Hi, this is Heather Grimshaw, Communications Manager for the Colorado State Innovation Model, and I am thrilled to be here today with Ben Miller, who is going to talk with us a little bit about his role in the Colorado State Innovation Model, which dates back, I believe, to the inception of the initiative. Yes.
Way back.
So Ben, would you introduce yourself for
Sure.
our listeners?
My name is Ben Miller, and I'm going to look at the microphone as I talk to you.
Yeah, absolutely.
I am an associate professor of family medicine at the University of Colorado School of Medicine, and I was the founding director of the Farley Health Policy Center. And now I'm currently the chief policy officer for a new foundation called Wellbeing Trust.
Wonderful. Okay, great. So can you tell us a little bit about Wellbeing Trust, just so folks have kind of a sense of your background?
Absolutely. So Wellbeing Trust is my new endeavor, but I'm an academic. I've been an academic for 9 years. And so I've been all about how can we increase the evidentiary support for things like integration? How can we get policymakers to pay attention to this idea that the mind and the body are actually not separate, they're together?
Right.
Wellbeing Trust is a foundation. It's an independent 501c3 that is all about investing in communities to advance mental health and wellness. So ideas that we see across the country where certain communities have really stepped up and said, you know what, here's the ways that we're going to most innovate around mental health. We want to support them financially. We also want to be able to partner with them in advance policy.
Wow. So kind of a continuation of what you've been doing.
Sure.
In Colorado and across the country.
Yeah, it's just now I get to work on with a foundation that has resources rather than always asking foundations for resources.
That's wonderful.
Yeah.
That's kind of the best of all worlds. Okay, so one of the things that I was hoping you would share a little bit about, or talk with us a little bit about today, is the concept of integration. And so for us, because we talk about it all the time, it's intuitive. But can you share with folks who might not know, first of all, what that term means and why we're even talking about integration, why it's important?
Before we talk about integration as a solution, let's talk about what the problem is, which
Perfect.
is fragmentation. And that's probably what most people are familiar with.
Okay.
Fragmentation's existed for a long time in healthcare. We've really had this place where we've asked people to work harder to get care that's best for them.
Right.
So we've got separate pots of money for this and for that. We've got different ways of delivering services depending on if it's a mental health or physical health. We've just got fragmentation everywhere. And that's because we have a hyper-specialized healthcare system,
Right.
where we got a lot of folks out there that do great work, but they focus on a small piece of the person.
Mm-hmm.
Integration recognizes that this is our reality, that this is what we've kind of inherited as individuals, and we want to do something to bring it all back together so it's about the whole of health.
Right.
So integration, the words that you can most commonly think of as important associated with that construct, if we can use that term, are things like seamless, whole, comprehensive. Integration rights a pretty significant wrong in healthcare, and we'll get more to that in just a minute with the whole mental health and physical health divide.
Yeah.
But as a whole, healthcare could benefit from being more integrated.
That's wonderful. Okay, so yeah, we talk a lot in SIM about whole person healthcare and kind of marrying or recognizing that the head is not separate from the body, which everybody kind of cocks their head and looks at me like, well, obviously. But in healthcare, as you mentioned, it really is separate in so many ways. And the Colorado State Innovation Model is helping primary care practices, as you know, in Colorado, really kind of pull those pieces back together. And so that was one of the other things I was hoping you would talk a little bit about, is really why Colorado chose to integrate care as part of the State Innovation Model, which is, as you know, very unique nationally.
Colorado has been a leader for many, many, many years in terms of how we can best integrate mental health and physical health. It has done some innovative projects. We've got a health foundation that's invested copious amounts of resources into it. We've got an academic institution that's really had major outspoken national leaders that have devoted their careers to addressing this. And most importantly, we've had communities that have been fighting this fight for a long time.
Right.
So it's almost like a perfect storm of bringing people together and having them address these issues around fragmentation, as I mentioned. So when SIM came about, or the opportunity for SIM came about, I think a lot of us that were having those discussions thought, here's one of the best chances for our state to scale and sustain what we know to be true. Mm-hmm. If integration is actually the future of healthcare delivery, and it is in some ways what people are beginning to ask or demand, why would we not think about a way that we could partner as a state with our federal partners back on the East Coast and say, let's come together and try and make this bigger and better. And so I think Colorado was ripe for that opportunity. We had good leadership. Mm-hmm. We had people that stepped up and said things like, this is a little bit risky, But if we're really going to be successful in changing the overall culture of health, we've got to take some risk. And so we did that. And now, as you know, 2.5 years in, however long we're in now, feels like forever. We're learning a lot.
Right.
Is it perfect? No, absolutely not. But we're making great strides, and we have become one of the best examples for other states to look to when it comes to integrated care.
And I know you do a lot of traveling nationally, and you're working with different SIM states, if I remember correctly,
Sure.
In various capacities. So I'm wondering, do you see other states doing some of this type of integration work? And if so, where are they in the process, and how does Colorado kind of compare with that?
Yeah, integration, specifically around mental health and primary care, is like the new shiny penny.
Okay.
Every state gets excited about it, and they want to go after this, and they want to say, you know what, here's what we're going to do. We're going to integrate care.
Right.
And I think that you could go to any state right now and hear, some echo of what's happening elsewhere. They're saying things like, well, we're going to try this in North Dakota.
Right.
Or we're going to try this in Arkansas. We're going to try this in New York. And people are moving pretty aggressively in that direction because of the data.
Sure.
And so let me take us back to that for a second, and then I want to dive a little bit deeper into what's unique about Colorado. I mean, if you just look at kind of national trends, we know that 46% of adults sometime in their lifetime are going to have a mental health or substance use need.
Right.
And if you look kind of where they go first, we know that all primary care visits, 20% of those are just on mental health.
Wow.
That's a lot of people.
It is.
And if you ask primary care docs and you say things like, well, what happens when you find someone that has a mental health or substance use need, 2/3 of them say that they can't get access to mental health services for those patients.
Right.
Which leads us to this final data point that 67% of folks that have some type of mental health or substance use need get no care.
Right.
All right, so we just kind of outlined logically these huge problems that exist. Other states are starting to pay attention to this, and they're starting to say things like, well, if that's the case, if what Miller's saying is true and those data are accurate, then we're probably losing a lot of money or spending a lot of money in places that we don't need to be spending.
Right.
Hypothetically, consider this. A person enters into a primary care practice, and they have some underlying mental health or substance use need. Okay, they say to their primary care provider, hey, listen, I think I got something going on. And the primary care provider, doing their best, might say, you know what, I don't do that, or why don't you go down the street, or, go see Dr. So-and-so, next month, whatever. We as people are busy. And sometimes that emotional toil of just kind of opening up and talking about something that was difficult might bring us down a little bit further. So we don't show up for the next appointment.
Right.
We get worse. We show up in the emergency department because we've got heart palpitations or our stomach hurts and we can't figure out why.
Right.
And it's because we never had some of these underlying issues addressed around mental health.
Exactly.
Huge problem. And if I'm a policymaker, if you're a policymaker, and we're kind of keeping an eye on the budget, and we're seeing how much things are costing, and we know that we need to get costs under control, this has become one of the most important areas for states to address to begin to control some of the costs.
Absolutely. And actually the actuarial reports for SIM are starting to show that already there's cost savings. So we're really excited to be able to release some of those findings, and I think our data people would probably kick me to hear that I announced that, but there it is. And it is very exciting to see that even 6 months in, data is showing that SIM practices are showing cost savings. So I think that will hopefully just increase that appeal for other states.
And let's talk about kind of history and culture here, because for 20 plus years, we've known that when you separate out mental health from physical care or mental health from primary care, that you pay more, you get less. Actually, Dr. Frank Degree over at the University of Colorado talks about you get inferior care.
Right.
And so it's kind of like, what took us so long to get here?
Right.
And I'm glad to see that we've culturally begun to shift this. But going back to what makes Colorado different from some of the other states is that we've been fighting this battle for a long time. And we've done some of the not so sexy work up front to get prepared for this.
Sure.
A couple of examples. One, we worked really hard to begin to define what integration was and was not.
Okay.
And so one of the common phenomenons that exist in other states is that a state might say, well, we're going to move towards this integrated care. And they've defined it so loosely that everybody says, well, I'm doing that.
Right.
And you can't measure it. There's no consistency. It's hard to scale, et cetera. So we did a lot of work around that at the beginning.
Very true.
The second thing, which I think is unique about Colorado, is the fact that we do have this multi-payer collaborative that gets together and talks about ways that they can begin to partner.
Yes.
That's unique.
That is unique.
Colorado having such kind of diversity in payers and having, not a massive amounts of one, but a lot of everybody. That brings us together and allows us to have different conversations. So I think that those two things really set us up to be unique examples for other states.
I agree. And I think that sometimes people will say Colorado made its work harder because, as you know, the SIM initiative in Colorado agreed not only to integrate behavioral and physical health, but do that with support from public and private payers. So your point about the multi-payer collaborative is very accurate and true. So I think one of the things, too, that I think is really powerful is when you look at some of the statistics with behavioral health, mental health, and the effects on productivity, let's say for self-insured employers, as well as cost. I think that kind of widens the scope. Can you talk a little bit about the work that you've done with some of the self-insured employers in the state, as well as maybe nationally, to raise awareness about this and ideally maybe share some examples of what self-insured employers might be able to do to help their employees live happier, healthier, whole health kind of lives?
Yeah, great question. Not my work, but in 2009, a gentleman named Ron Lupke published a paper that I think really highlights a lot of what you're talking about. It looked at what employers are spending most of their resources on. Right. And number one on that list was depression. Okay. Number one. And if you look at what they were spending the most amount of dollars on for depression, it was, as you described, these productivity measures or metrics. So absenteeism and presenteeism. Okay, it's just like, what day is today? Monday?
Yes.
Okay, so Monday, most people come to work, and it's Monday morning. They just had a great weekend, and they don't want to be back at work. And so they just kind of sit there, and they stare at the wall.
Right.
Okay, that's normal behavior. But when you're depressed and you do that, that's what we would call presenteeism.
Okay.
Where you're present, but you're not being productive.
Okay.
That costs employers a substantial amount of money because they're relying on you to get something done.
Right.
So presenteeism is one piece that goes into productivity. The second piece is what we call absenteeism. And this is when you don't show up.
Sure.
Okay. Now that might be us on Mondays too, but with individuals that might have some type of mental health or substance use underlying need, they may not want to get out of bed.
Right.
They may be stuck on the couch and they might be saying things like, well, why would I go to work? What's the point?
Sure.
And so employers spend a lot of money just on depression. And ways that employers might be more considerate of their employees in recognition of these data is they might consider what type of workplace wellness plans or any type of benefit structure they have to accommodate mental health.
Nice.
Now, this is relatively common these days, but it didn't used to be, where employers might have, an EAP program, an employee assistance program,
right,
where somebody showed up and once a month they would go around and they would screen individuals for substance use, or they would do a PHQ-9, which is a screening tool for depression, and they would talk about kind of feelings, and if there was somebody that got hurt, they would process that, and that's cool. Mm-hmm. That's actually a really important kind of triage first step. Now most employers are getting hip to this cause, and they do have EAPs. And even if you're a small independent employer and you're paying for your own health insurance, you might subcontract out with someone else for a piece of an EAP. I don't know.
Right.
The point is that you have someone that's coming to you to assess your population. Right. Now let me kind of separate this out, because what we do in most facets of life, especially healthcare, is that we ask people to come to us.
Right.
We send them out. You show up at work and you feel really bad and you don't necessarily want to leave work, but you need to get something taken care of. Mm-hmm. We ask you to come to us. Come see us next week. Take off work, get there, etc.
Right.
What happens if you bring those services to the employer, right? Large employers, let me go up for a minute, are doing this direct contract all the time. They're going directly to health plans and saying, you know what, you can manage my population. Boeing in Washington's done this.
Right.
Be at risk for all my population, put primary care on site in my facility, and then let my people come to you in my own building so they don't have to leave.
Right.
That's kind of a novelty. Now, some of our small onesie-twosies can't do that.
Right.
But the point is that if you recognize how much money you actually pay for your employees, no matter how big or small you are,
right,
it actually forces you to begin to think of strategies where you can bring services to them. Sure. And begin to assess more proactively before it becomes a problem.
Excellent. Yeah, and I do hear about increasingly the on-site primary care. The other part of it that I'm interested in too with self-insured employers is that mental health stigma piece. So if you're trying to encourage your employees to look at health holistically as that whole person, one of the things the SIM team is trying to do is encourage employers to really address mental health as well as physical health. And a lot of people kind of look at me with a questioning glance when that happens, because it's always more of a question of how do you do that? Yeah. So I'm curious if you've heard about effective approaches or anything that you're kind of following.
Yeah, this is a great question, Heather, and it actually speaks to the larger issue of stigma. And so what is stigma? Well, people most oftenly associate stigma to attitudes. It's like, well, they think they're going to judge me because I've come out and said, I have depression,
right,
or, whatever it might be. Mm-hmm. But stigma is actually the power differential between the person that's explaining what's happening and then someone else somewhere that does something because of what you told them.
Right.
And so stigma can be, at a practical level, can be an employer firing you because you are depressed.
Right.
Okay, I mean, it could be an employer saying, well, you can't do this job because I'm worried about your emotional state. Now, there's some truth to being worry about your individuals and their health and their status.
Sure.
But it puts all the impetus back on the person and doesn't really allow for the system of care that we can take care of the individual. The employer might say, well, what can we do to help you? Instead, we're going to punish you for being sick.
Right.
And so that's a big piece, is understanding that the power differential. So policy plays a major role here.
Yes.
There are policies that exist at multiple levels, state, system, community, whatever, that actually are punitive in nature when you disclose that you might have a substance use or mental health need.
Right.
And we have to change that. Now, I don't know what they are off the top of my head for Colorado. I can't even begin to go there. But I guarantee you, if you just let's do a 5-mile walk around where we are today, you're going to find that people have unspoken policy, attitudes around mental health. Mm-hmm. And so they might decide they want to let you go just because you've disclose some type of mental health need, or there might actually be a policy that says we reserve the right to let you go when you tell us that X, Y, or Z. That is so archaic,
right,
and so bass backwards, if I can use that term.
Absolutely.
That it really is not fair for people to ever speak up and to seek care. Right. That's stigma.
Yep.
And so what do? Well, first of all, we're drawing attention to it, which knowledge is totally insufficient to bring about change here. Sure. But we're at least drawing attention to this issue, that mental health is just a part of health.
Exactly.
That's a huge one. Number two, we're beginning to demonstrate through our own values, the state is, that by addressing the whole of health, we can indeed have a more productive and healthier society that saves money for everybody.
Absolutely.
I don't see how those are bad things to chase when you're constantly in the hunt for what's going to be best for my people.
True. And we interviewed or chatted with the folks who started Let's Talk Colorado, which is one of the campaigns that SIM funded. And I think one of the most helpful pieces of that resource is that they actually give you suggestions on ways that you can talk with people about mental health, which is an area I think a lot of people are uncomfortable with. So I think that guidance is really helpful.
Absolutely. Sometimes our language inadvertently reinforces some of these, predominant stigma issues. Sure. Just think about it for a second. He's crazy.
Yep.
Or, you can think of thousands of examples where we improperly use language to express real concerns that people have.
Right.
If you're the individual that's feeling down or sad or blue or whatever the emotion might be, and someone knows that you're off your game and they describe you as crazy,
right,
think about that, how that reinforces that negative stereotype
Absolutely.
Of the person. There's stigma again, because there's a power differential now between the person that sees themselves as quote unquote normal, mm-hmm, and the person that realizes that there's something going on.
Right, absolutely. I think you're 100% right. And the more you start to think about it and have that discussion, I think it's so helpful, because then it normalizes it, if you will. I'm using air quotes, so that hopefully people do feel more comfortable having those conversations. And I'm always so impressed when people are brave enough to broach those topics, and then you see people say, oh, I didn't realize, and they kind of lean in and share things about themselves that really help facilitate better health overall.
20, 25 years from now, maybe less, our kids are going to look back and laugh at how ridiculous we treated mental health, and how, wow, they thought they were doing something really innovative,
right,
by talking about depression.
Right.
It's just so funny. I don't even think, my kids, while they know what their dad does, I don't think they would describe what I do as quote unquote mental health.
Right.
Daddy does whole health, or he does health,
yeah,
or healthcare or health policy. It's not mental health.
Which is wonderful.
Yeah.
That's great. I think one of the other things that I was hoping you would talk with us a little bit about, that I hear providers talk about in terms of mental health, behavioral health, that whole person care delivery, is really recognizing that if you can get over the hurdle of the fear associated, which exists in primary care practices as well. A lot of providers talk about workforce shortages, and since you are part of that SIM workforce work group, I was hoping that you could share a little bit about what you guys are working on and some of the ideas that you're sharing.
Sure, thanks for asking that. I chair the workforce work group with a good friend and colleague, Michael Telemontes at DU, University of Denver. And we started early on for SIM trying to address what we thought were some of the basic needs around workforce. And an example of this is that we recognized, a lot of the group did, including Michael, that there was no consistent standard of what we were expecting from our mental health clinicians when they went to work in places like primary care. Everybody had their own opinion on this, and there was no consistency. And so we created competencies built off the evidence, the literature, and we put that into play, and we gave that as a resource that other people can use. There's 8 of them, and we don't need to walk through that today. But the cool part about those competencies, and I'll talk more about the workforce work group, is that we actually have video vignettes that are coming out that explain each one of them in detail. So animated vignettes of these really cool cartoonish characters that are showing you how to assess an individual when they show up in primary care, or how to build the team, or how to do all these other various pieces that are essential in a high-functioning primary care practice. But back to your question around shortages and what the workforce work group is doing there. We pretty much decided early on that when it comes to workforce, that the answer to the question of what do we do around shortages can't be let's get more.
Right.
We know that that's insufficient. Our good friend Steve Holloway here at CDPHE has really helped us understand that everybody is struggling with finding the right clinicians. Right. And you're never going to be able to find enough. An example of this is there was a report that came out that said to currently meet the demand of child and adolescents that have mental health needs, we need 66,000 new child and adolescent psychiatrists.
Oh, wow.
Well, that's today. Where are they going to come from tomorrow?
Yikes. I didn't realize it was that high.
Oh, yeah, it's ridiculous. And so when you think about that, we're never going to be able to get to that. How do we begin to think differently around the solutions? And so a couple of ideas that our workforce work group is really kind of, addressing or struggling with is around distribution. Where are the majority of the individuals that need mental health care, and where are the majority of the individuals that can deliver care for mental health?
Right.
Are there some more creative ways to redistribute the licensed workforce out into other domains? Let's get them into schools. Let's get them into primary care. Let's get them into our faith community. I mean, for heaven's sake, let's get them at the grocery store where everybody goes on Saturday morning when you need more milk for your coffee.
Right.
Why not normalize mental health as a delivery mechanism in places that are far outside the mental health centers? That's number one. Number two is we've got to begin to think about workforce beyond just licensed clinicians. While, don't get me wrong, there's a reason that we license people. We want to make sure that we can protect the public and that we have good standards of care. But there's also a lot of individuals out there that don't have a license, that have lived experience, that can be profound and powerful interveners around mental health.
Absolutely.
You can think of this as peer support, you can think of this as whatever, but it's really about this community function where if I'm living in Northeast Colorado, I'm out in the plains, and I might know all 12 people within 10 miles. How do I train one of us to be able to talk about issues around mental health and wellness? I mean, that's a novelty, right?
It is.
I'm not asking you to be the person on record that's treating me. I'm asking you to be a friend.
Right.
And I believe that's how we change some of this discussion around workforce, is that we recognize that it's much bigger than just more, and it's much more complicated than just who, and it actually gets to the heart of culture and being able to spread mental health almost everywhere as a part of our approaches to address community health.
That's a great point. And I do think that, especially depending on where you live, access is an even bigger issue. And those peer support programs have proven to be very successful in myriad settings. So I think it's a great point.
Well, and in this day and age, I mean, when we can hop on our phones or our computers and have instantaneous access to practically everything,
right.
Access seems to be also somewhat of a really antiquated and archaic principle.
Right.
Like, I have to wait to get in to see who? It's almost like, well, really? I mean, this is 2000 and what?
Right.
And you're telling me I'm going to wait 6 weeks? I mean, think of another professional service where that's the case, where you actually have to wait so long to get in.
Right.
Even if you wanted to have your car totally redone, I guarantee you can get in this week.
Absolutely.
You're not waiting 4 to 6 weeks. You're not being put on a wait list. And then we complicate it by having things like, well, am I covered by this particular health plan for this particular individual?
Absolutely.
All of these things bring us back to this need, and I'm glad to be able to say this to you, where I think it's time for our community, those that have experienced kind of fragmentation and also through some experienced integration, to rise up and almost demand for something more than what they're getting.
Absolutely. Yeah, I think that, so SIM, as you know, will reach 400 primary care practices and 4 community mental health centers during its 4-year timeline, which ends now in 2019. So I do think as we turn our attention to sustainability, we're all looking at some really what we think of as innovative ideas,
Sure.
to your point, with the community peers and some of those different access solutions.
Mm-hmm.
But I do think that increasingly it will be patients who have to really demand that. And it's almost as if I had planted that quote with you, because I think one of the things that I continue to try and work on is really engaging consumers in the discussion. Mm-hmm. And so we've worked with a couple of different groups, including our volunteers with the Consumer Engagement Work Group, to really start talking about what integrated care looks like, what value-based payment looks like, which ultimately supports integrated care.
Right.
But oftentimes patients sort of glaze over when you talk about that. And it's really that nuance or the business of healthcare that doesn't appeal or resonate. Yeah. And so I wonder, when you talk about that in terms of that, that group rising up, which I love, what does that look like to you, and what do you think the SIM team and the folks who are listening to our discussion, what can we do to facilitate it?
Yeah, great question. So first of all, if you look at the evidence, most people are pretty satisfied with healthcare until they get sick.
Right.
So the vast majority of people that are even going to listen to this or are out there hearing ruminations around what's happening with SIM don't truly appreciate what it is trying to do, because they've never been in the system or experienced this. So let's just start there, that most people don't get it because they haven't had the opportunity to understand how bad it is.
Right.
Okay, so one, we have to educate people a little bit differently if they've interacted with the system versus not. Mm-hmm. So we might have 2 communication strategies. For the general public who may or may not have ever used healthcare, to educate them on what is going right or wrong with what we're doing, but also those people that are out there that have been in the system and know how challenging it is. They might be our most powerful voice when they stand up on the Hill and talk about how, whoever needs to change whatever to allow for integration to be the standard of care. So that's a big bucket.
Yep.
The second bucket, which I think is a little bit more close to home, and so I get to say things here that probably you can't, but I think that we have a governor's race coming up in November.
Yes, we do.
And our governor currently has been very supportive of SIM and really outspoken on this need to address health and health care.
Yes.
We were a Medicaid expansion state. We have a strong insurance exchange. We've done a lot of great stuff.
Right.
However, mental health is still ripe for major disruption. And SIM is almost a drop in the bucket of larger things that need to unfold or happen in the state. Mm-hmm. So how could we, looking forward to 2018 and these massive races that are going to unfold, use SIM as a major platform to build off of for larger reform around mental health?
Right.
It would be almost unheard of. Excuse me, let me back up. There are 2 gubernatorial elections happening right now in November. And in both of those races, mental health has been brought up in pretty major ways, because in both of those states, we know that they have not done the best job of addressing mental health. So all the candidates on both sides are talking about this.
Right.
In our state, a state that has such a profound and strong platform like SIM to build off of, it would be a shame for our candidates on both sides to not also be talking about this.
That's a great point. That's a very good point. I like that a lot. Yeah, I do. I agree. It's just rich territory, and I do think that both with Hickenlooper as well as with Donna Lynn, who has such a strong healthcare background, that support for SIM has been really important and powerful. So lots of things to think about as we gear up for 2018.
Well, and just one more point here. I love the way that you just articulated that, because Governor Hickenlooper, being a very profound businessman, Lieutenant Governor Lynn and all that she's done in health and healthcare, as well as having a very savvy public health and business background, those 2 coming together is potent for this. And I think they have laid a very firm foundation for what's to happen next.
Right.
But, and this is my word of caution here, SIM can't be seen as a project.
No.
It can't be seen as just like, oh man, we got X amount of dollars from the feds to do this really cool integrated work, and now we did it. It's 2019, and we've got 400 practices integrated, and then we just walk away saying, hey, we're done.
Yeah, worst case scenario.
That's right. If we do not take advantage of this, then we have no one to blame but ourselves.
Agreed.
We've got to build off of this and do something bigger.
I agree. Absolutely. Well, we so appreciate your willingness to chat with us about this, and I know how busy your week is. So thank you so much for your time, and I hope you'll come back and talk with us again as things continue to evolve.
Absolutely. Thank you.